Hello, this is Dr. Philip May, and I will be speaking with you about the clinical use of biochemical markers of bone turnover and bone physiology in clinical practice. First, let's talk about the skeleton. The function of the skeleton is organ support, of course, storage of calcium, and it also serves as a source of calcium, serum calcium, when calcium is needed to maintain normal calcium homeostasis. And this is a very important function. We always think of the skeleton as supporting our organs. We would be a mass of jello if we didn't have a skeleton, but we usually don't consider how important the skeleton is as serving as a source of serum calcium, so that the blood levels of calcium can be maintained if they're needed. For example, if you were not getting enough vitamin D and calcium, and the gastrointestinal absorption of calcium was deficient, you still need calcium in the blood. So fortunately, you have a skeleton there that can take the calcium out of the skeleton when it's needed. Of course, the problem is if that process becomes chronic, if you remain deficient in vitamin D and calcium, and you start depending on the skeleton as your major source of calcium, then the bones get weak and you become prone to fracture. Now, there's three types of bone cells: the osteoblast, the osteoclast, and the osteocyte. The osteoblast is the bone formation cell. The osteoclast is the bone resorption cell, and the osteocyte serves as the mechanostat. It senses mechanical pressure in the bone. The osteoblast produces a number of substances, one of which is P1NP, and that stands for procollagen type 1 N propeptide, and that's a clinically useful measure of bone formation. There are others, but this is an especially useful one. The osteoclast is a cell that causes resorption of bone, and it produces a substance known as CTX, or C-terminal telopeptide of type 1 collagen. The osteocyte produces a substance called sclerostin, and sclerostin will inhibit bone formation and may have other functions as well, but it's emerging information about sclerostin and osteocytes, which appear to be very important. Now, focusing on the osteoblast is the cell that produces matrix, osteoid matrix, which is the jello-like substance that is needed for calcium phosphate to precipitate in. And of course, P1NP is an indication of production of osteoid. The osteoblast also expresses a substance on the cell membrane known as rank ligand, and rank stands for receptor activator of nuclear factor kappa B. It's a mouthful, but basically rank ligand is a stimulant to produce osteoclast, converting macrophages in the blood to osteoclast. Now, when osteoblasts are stimulated by parathyroid hormone, bone formation and bone resorption are stimulated. Thus, you hear the term coupling, because bone formation and bone resorption are linked. Now, this is a representation of what the osteoblast does. Again, you can see the the rank ligand on the osteoblast on the top there, the yellow cell, and the macrophage, the circulating macrophage, has rank on its cell membranes for the rank ligand to interact with. Now there's one other substance that we need to consider, and that is OPG, or osteoprotegerin. Osteoprotegerin, or OPG, actually blocks the action of rank ligand. So it's important to know about that, because there are drugs, for example, Prolia, which acts like OPG, and it blocks the rank ligand. So if the macrophage is blocked like that, it will not be converted to an osteoclast. So this is one way you can inhibit osteoclast production and stop the osteoclast from removing calcium from bone. Again, the osteoclast secretes peptidases, for example, cathepsin K, which generate production of CTX. And CTX is what that stands for is a C-terminal telopeptide of type 1 collagen. And this is a fragment that results from the breakdown of collagen. The osteoclast also produces hydrochloric acid, which dissolves the mineral hydroxyapatite and releases calcium into the serum. And here is a nice picture of the osteoclast and how it seals itself to the bone and starts releasing hydrochloric acid and enzymes like cathepsin K, and the combination of the hydrochloric acid and the proteolytic enzymes lead to the dissolving of bone and release of calcium into the bloodstream when it's needed. Now there's a drug that's being developed called donacativ, and it's probably going to be released within the next couple of years, and it's an antibody against cathepsin K. So this is one way that you'll be able to block the action of the osteoclast and stopping the demineralization of bone. Now, this is just to review once again that you can stop osteoclast activity with OPG, and you can see how the OPG molecule fits into between the rank and the rank ligand to prevent the formation of the osteoclast. The third cell, we just talked about the osteoblast and the osteoclast, but the third cell is the osteocyte. And the osteocyte secretes sclerostin, which will inhibit the osteoblast from forming bone. It does not stop bone resorption. So with a lot of sclerostin being released, bone formation will be inhibited, but resorption of bone can continue. And this can happen with loss of physical activity. The mechanosensor function can actually steal mineral from mineral-rich sites in bone and give it to the mineral poor sites to strengthen the weaker areas when needed. But it also, part of that process will inhibit bone formation as it causes or leads to release of calcium. And this can actually, with physical inactivity, you can actually have a period of elevated serum calcium as the calcium is being released into the bloodstream. You can get hypercalcemia. And here's a picture of a diagram of the osteocyte. Seeing the blue circles there, and how it produces sclerostin. And if you can just look at the slide for a minute, you can see the osteoid down at the bottom there, the pink substance. You can see up at the top, there's a thin line of osteoid, meaning that the sclerostin is inhibiting the osteoblasts from making the osteoid. But this process is stimulated by the osteocyte. You can see on the left-hand side of the slide where it says mechanical loading. That means there's pressure, weight-bearing physical activity on the bone that's stimulating the osteocytes that have all these dendritic processes, and this leads to release of sclerostin, which interferes with osteoblast function. And here there's WNT or Wnt. This is Wnt. This refers to a genetic pathway discovered in fruit flies, but it's important for a lot of different functions. So this may be involved in this whole process. It's getting to be very complicated. But the point is that when sclerostin is being released, bone formation is inhibited. And you should know that within the next couple of years, probably, there will be a drug which is an antibody against sclerostin, which you can use, which will stimulate bone formation. So it's important to know about this physiology, because the drug treatments that physicians use are based on this physiology. And here's a photomicrograph of the osteocyte showing the dendritic processes. This is taken from a lecture by Dr. Nancy Lane, who's an expert in bone metabolism. And just to summarize the process, starting with at the top there, you have resorption of bone accomplished by osteoclasts, and of course the target of the bisphosphonates is the osteoclast. You inhibit resorption of bone with osteoclast, and but the normal process eventually with osteoclast activity, eventually they will die off, and osteoblasts will move in and reverse the process, start producing osteoid. Osteoid will form and eventually build new bone once the mineral deposits into the space, into the osteoid there. Just to mention a parathyroid hormone, which is a key stimulant of the whole process. The parathyroid hormone secretion is inhibited by free serum calcium. So when the serum calcium drops, parathyroid hormone secretion will increase, and this will then lead to stimulation of active vitamin D. That's the 125 dihydroxy vitamin D, and in the kidney. And this leads to, once the vitamin D becomes active, then there can be enhanced intestinal absorption of calcium. Parathyroid hormone also stimulates osteoblastic activity to produce rank ligand. So both the anabolic and resorptive activities increase once the osteoblasts are stimulated by parathyroid hormone. the anabolic activity of osteoblasts, you'll recall, are blocked by sclerostin. Now, the 1,25-dihydroxyvitamin D also stimulates renal reabsorption of filtered calcium in conjunction with parathyroid hormone. So the vitamin D and parathyroid hormone seem to work together. And this is a kind of a summary slide. It's very complex, but OB stands for osteoblast, and the OC in white there is osteoclast. And this slide just tries to put together all the different factors that are involved in bone turnover and bone remodeling. And down at the bottom of that slide, I think this is an important point, is that the resorption occurs in 20 days and the formation is long, it's 100 days. So in a couple of weeks you have resorption, but formation takes a few months. So the osteoclastic activity is very rapid, and of course that's important because if your serum calcium levels drop, you need to quickly get those back up, and that's where the osteoclasts become activated and they take calcium out. But it takes a long time to repair that bone once that happens. So you want to prevent that process as much as possible with adequate vitamin D and calcium, so that you don't have to call on the osteoclast to supply you with adequate serum calcium. Okay, here's the just another shot at the bone turnover cycle. Now, let's get into some clinical issues here. How do we measure all this process? How does the physician evaluate his patient to see what's going on? And the serum bone turnover markers are very useful. Bone turnover markers predict bone loss and fracture risk in patients who are not being treated. But with treatment, there's a change of bone markers sooner, serum bone markers, much sooner than you see with the bone mineral density on DEXA. So you can identify more responders to treatment than you can with the DEXA bone mineral density test. And the bone turnover markers actually explain the greater proportion of fracture reduction than the change in bone mineral density. And you can see this change in bone markers within a couple of months, whereas you might have to wait a year or two to see a change in bone mineral density. So reducing bone turnover is an important strategy in reducing risk for fracture. And the bone turnover markers can be useful in monitoring the response to treatment as well, whether it's treatment with bisphosphonates or drugs like Forteo. Now, this is a slide from Dr. Nancy Lane, who's an expert in bone metabolism. She's a professor of medicine at University of California, Davis Medical Center in Sacramento. And this is how she uses markers. She uses them in untreated patients who have high baseline values. And she suggests you think beyond postmenopausal osteoporosis. These people are rapid bone losers, so it can be useful in assessing conditions other than postmenopausal osteoporosis, if they're very high. For example, vitamin D deficiency and of course a lot of other possibilities. But in untreated patients, high values may tip the scale in those with borderline risk for fracture. And who may have a kind of a borderline bone mineral density, but having the bone markers elevated is another thing to consider, and may tip you towards treating that patient. In treated patients, the values above the clinical trial treatment group suggests poor compliance, poor absorption of, or poor bone biological effects. So if you see elevated bone marker levels in people who are being treated with bisphosphonates, something's wrong. So you have to evaluate why this is occurring, whether it's absorption or compliance or just something interfering with the action of bisphosphonate, maybe diabetes or some condition, some drugs that may be interfering with the bisphosphonates. But the elevated bone markers suggest that process may be going on. Again, in treated patients, looking at a change, at a decline from anti-resorptive treatment or an increase from anabolic treatments from the baseline is encouraging to Dr. Lane and to the patient. So it's nice to be able to report to the patient, hey, we've started you on bisphosphonate, and we have a good suppression of your CTX, and this is looking good. And also, they can be used in drug holidays or discontinuing drugs to see if the metabolism gets worse. And this is a nice flow chart here, an algorithm of sorts that Dr. Lane has developed. And once she diagnoses osteoporosis, she measures the P1NP and CTX baseline values, whether you're using anti-resorptive or anabolic therapies. Then you start treatment, and after 90 days, you monitor the markers with P1NP and CTX, and depending upon how they respond, you either maintain the therapeutic regimen or you have to change something. So, this is her approach, and I believe that most of the experts that use routinely bone markers in their practice follow something like this. Okay, specifically the drug holiday issue. This is one perspective that's been published, is that most patients don't stay on therapy very long. In the United States, patients stop on their own, and doctors are often afraid to treat patients for osteoporosis. The legal threat is there if a patient fractures on or off a bisphosphonate. So that's something to consider. Creates a dilemma. The skeletal load of a bisphosphonate may differ greatly from patient to patient on the same bisphosphonate or among different bisphosphonates. And if the bisphosphonates are stopped, serial bone mineral density and bone turnover markers are the only clinical tools we have to monitor the effect of stopping the bisphosphonate. And I think this is the most important point. And now Dr. Lane uses, this is how Dr. Lane uses bone turnover markers with drug holidays. She checks a CTX or an NTX or a P1NP when stopping the bisphosphonates, and then she rechecks them after a year off the bisphosphonate, and if they're greater than 50%, she rechecks the bone mineral density of the lumbar spine or total hip or femoral neck, and if the bone mineral density is decreased such that the T-score is less than or equal to minus 2.5, or the subject patient has sustained a fracture, she will restart the medication. And she says when she follows this regimen of over 300 patients that she's treated, she has only had to restart bisphosphonates in 2. Now, so what she's saying is that when you recheck the bone turnover marker after a year off of the bisphosphonate, if it's not elevated, then she doesn't recheck the bone mineral density as often. They don't have to be closely monitored. But if that bone marker goes way up and increases greater than 50%, then you really have to work that patient up and check the DEXA, the bone mineral density again, and make a decision about having to restart. But apparently that doesn't happen very often with Dr. Lane. Okay. Finally, bone markers are covered by Medicare, and the Medicare, the appropriate use to get Medicare reimbursement. You get 1 or 2 baseline assays from urine, but I think this is an old slide here from 10 years old. And there are probably some changes that the doctors need to check into. I think they're a little more, they allow any method for cross-links. It doesn't necessarily have to be a urine, and probably more and more using the serum CTX rather than the urine NTX. But to get a baseline on a couple of different days to show how much variation there is between the assays, and then repeat the assays in 3 months, and then that's after starting anti-resorptive therapy, and then a follow-up a year after that. Then after that, once a year is sufficient. So this is the guidelines from Medicare. People do things differently. I know there's some experts don't get baselines. They go with different criteria. But this is an evolving, emerging area, and it's something for a primary care physician to consider in their treatment of patients with metabolic bone disorder. Okay, thank you very much for listening, and stay tuned for other talks in this about bone health and evaluation and management of osteoporosis and osteomalacia in patients with complex disabilities. Bye-bye.